Bismillahir Rahmanir Rahim.
शुरू अल्लाह के नाम से जो रहमान और रहीम है।
Qul a'udhu bi rabbil falaq.
कहो मैं पनाह मांगता हूँ सुबह के रब की,
Min sharri ma khalaq.
हर उस चीज के शर से जो उसने पैदा की है,
Wa min sharri ghasiqin idha waqab.
और रात की तारीकी के शर से जबकि वो छा जाए,
وَمِن شَرِّ النَّفَّاثَاتِ فِي الْعُقَدِ.
और गिरहों में फूंकने वालों या वालियों के शर से,
وَمِن شَرِّ حَاسِدٍ إِذَا حَسَدَ.
और हासिद के शर से जबकि वो हसद करे।
Timely diagnosis and appropriate interventions, the disability effects can be minimized. This requires awareness of disease symptoms amongst the general public, patient population, and physicians to enable them to timely recognize multiple sclerosis. It also requires good diagnostics and thorough knowledge of the disease. MS and its associated disorders have been historically considered to be rare in our part of the world. However, recent regional data, especially from Iran, suggests otherwise, and it is not as rare as previously thought. This necessitates the need for creating a forum where neurophysicians specifically and doctors community and at large can discuss MS and related disorders in order to educate themselves and to share their experiences. These are exciting times in the fields of neuroimmunology, where new treatment modalities are being discovered, updates are being diagnostic criteria. As we'll soon see in the upcoming sessions, inshallah. And last but not least, we'll be going through patients' perspective regarding their disease journey and how to harness the limited but available healthcare resources for optimization of patient care. So we have an excellent program lined up with national and international speakers. A special welcome to our virtual attendees who have joined us for this morning's session. I again welcome you all. And now we'll proceed with the first session. Dr. Naveed.
Thank you, sir. So we will start with our first session, and I would like to introduce our chair, Professor Dr. Mazhar Badshah. I think Professor Dr. Mazhar Badshah does not need any introduction. And we have our co-chair, Dr. Yasir Mahmood Malik. He's a trained physician from Pakistan Institute of Medical Sciences with international experience and is currently the head of Department Neurology in KRL Hospital. And also we have Dr. Zakir Jan, who is an assistant professor. And also like to say that he's an excellent. The co-chairs, I would like you to call the speakers and introduce them, please.
Thank you, Dr. Naveed. So we'll proceed with our first session. Our first speaker of the day is Dr. Professor Mohammad Wasay. Professor Mohammad Wasay, he did his formal education from Aachen University in Medicine and Neurology. After that, he did FRCP from Edinburgh, and he's a fellow of American Academy of Neurology. He's having a special interest in research, and he's a leading author of multiple national and international journals, articles. And he is the inspirator, creator, and the main author of many of the trials going nationally and internationally. He will be speaking about MS treatment, paradigm in Pakistan, plus challenges and opportunities.
Bismillahirrahmanirrahim. First of all, I thank all the participants for being here for this second MS conference. I would especially thank Dr. Haris for organizing this activity. Now, Haris is also the coordinator of our MS Education and Research Forum, and he has been organizing MS awareness and MS education and training activities for many years. I will give you an overview that what this forum is working for the last many years. And in this presentation, what we'll be discussing that what is the current knowledge related to multiple sclerosis in Pakistan, and what are the plans to promote this education related to MS in Pakistan. So this is our topic for discussion today. So I thank all the participants. We have about 250 participants on Zoom who are attending this conference across the country, and even outside country. We have speakers from US, India, Saudi Arabia, Turkey, so about different parts of the world, and we will be discussing important aspects of MS treatment in Pakistan. So this is, I think, an important conference, and this is the first time we are doing in Islamabad, and we hope to do it in other cities of the country over a period of time in the future. So should we start? Okay. Now, as you already know that global burden of MS is pretty high, and now there is some evidence that it's increasing over a period of time. So it used to be 30 per 100,000. In 2013, it's 33 per 100,000. It's about 37 per 100,000 in 2020. So it is increasing over a period of time. Now, a lot of people say that why it's increasing, because the number of neurologists are increasing and number of magnets are increasing. So all the places where they used to have 2 or 3 neurologists and 1 MRI, they say we have no MS or very little MS. And now they have 50 neurologists and 10 MRIs. So they say that, we have got more MS than we used to have. And same thing happened in Iran. We have pretty good data from Iran that 10 years ago or 15 years ago in Iran, MS prevalence was 5 per 100,000. Then they have got more neurologists and more MRIs, so it became 10 per 100,000. And maybe in 2017-18, it was 15 per 100,000, and now it's about 22 per 100,000. So patients are there, and that's what I think in Pakistan too. So we have a number of patients in Pakistan, but they are not being diagnosed, and they are not taken to the neurology. They have not got an MRI or those kind of things. So at this point, Pakistan falls in the low category zone, which is a less than 5 per 100,000 population as far as the known data is concerned. We don't have any population-based studies. Hopefully, in 2023, we will be able to do a population-based study. We have a grant at the PHRI, and hopefully, if that's accepted, then we will do a population-based prevalence of neurological diseases and MS. So we will be able to find out that what's the population-based prevalence of multiple sclerosis in Pakistan. But so far, Pakistan is in the low frequency zone. But if we have more data, and if we have more neurologists, and if we have more ability to diagnose, we may be able to find out that we are not in the low frequency zone. We may be in the mid frequency zone, which is like 10 per 100,000 or even more. So regional burden, as we know that it's becoming higher and higher as we see growth of neurologists in the country and the ability to diagnose. In India, it was 5 per 100,000. Now it's about 5 to 10 per 100,000. So in Iran, now it's about 22 per 100,000. In Pakistan, we don't have any population. We think that it's probably about the same. Now, if we compare the data of MS in Pakistan as compared to other Asian countries, so there are certain differences in terms of prevalence and in terms of type of MS. Now, we published this, started working on this MS in Pakistan data, especially with the help of Haris, that we have reviewed all the literature related to MS in Pakistan. And it's all together, it's about 15 to 20 reports. So that's the whole literature related to MS in Pakistan. I'm talking about published paper. And they're all hospital-based, some single or some multi-center studies. Altogether, we have less than 1,000 patients reported in that literature. So this is something which is kind of it's very poorly reported in Pakistan. Some people have used different criteria for diagnosis and different outcome assessment. So at this point, no population-based prevalence, but we have some hospital-based data. So this is, I think, one thing which we want to promote, and we will be discussing that how can we promote MS-related data or registry in Pakistan? So get more accurate data related to MS in Pakistan. Now, that will help us to identify the types and the treatment outcomes and what can we do for these patients. This is a project we started in 2006, which was MS database in Pakistan. And we were able to get 5 centers from the country, and we collected 142 cases. And that was the first largest published study of MS from Pakistan. That was a retrospective review, but it was published in MS Journal, which is the premier multiple sclerosis journal in Pakistan. So it was a multi-center study, and there were very important findings, which I think made to this journal. A lot of people thought that aptecospinal MS was very common in Pakistan, but actually it is common as compared to US or Western population, but it's much less common as compared to a Far Eastern population. So mostly we had relapsing remitting MS, and then we have primary progressive MS and secondary progressive MS. The important finding was that almost 3/4 of our patients, 75 for patients, and this is the tertiary care center data. So obviously, most people who were coming to the hospital, they were severe as compared to other hospitals. So they were very severely disabled. So disability was high in our population, and about 60% patients, 65% patients became disabled within 5 years, which is a very rapid onset. Usually it takes about 10 years for a person with MS who is not getting the right treatment to get a EDSS of 6. And that was like less than 5 years, they were kind of on wheelchair and they were not able to walk. So this was something very striking, that we not are seeing these centers, at least they were seeing very aggressive forms of MS and very severe forms of MS. So that was a important data. Now this is another piece of paper we got to collected, that what is the incidental MS in Pakistan. And that tells that, you know, a lot of patients are still there and we are unable to diagnose these patients, or we are not diagnosing these patients. So this is a collaborative study we did with the neurology, radiology, and Karolinska, and there's no study on incidental MS in our region at that time. So that was started in 2008, and that was published in the Journal of Neurology, Neurosurgery, and Psychiatry. And that was a important study which tells us that, you know, there may be MS out there, but we are unable to diagnose, and this is something we should work in future. So out of 864 MRIs that were done for other reasons like headache or some other reasons, there were 6 MRIs which fulfilled the criteria, MRI criteria of multiple sclerosis. So that was about 0.7%. And they have a large number of lesions, like average 9 lesions, all of them had. And then we reported that, you know, Pakistan is a very low prevalence area, but even in 1% patients of MRIs who are getting MRIs for some other reason, to find MS-like lesion, I think that was a lot of MS. And then we followed these patients for over a period of time, and actually one was lost, and out of these 6, 5 actually developed MS over a period of time. So they, at that time, that was a radiologically isolated syndrome, but after a few years, they developed clinical multiple sclerosis. So it means if you are able to diagnose them early in the case, at least you know, and sometime now there is good data that you can treat these patients and you can prevent these patients from developing multiple sclerosis. Now, this is another piece of data which may be important for us in future, is to identify that what kind of genetic profile of our MS patients have. And that's a study we started in 2009 and it was completed in 2010. And that was again a prospective study that was again published in Multiple Sclerosis Journal. And this is also a good study because a lot of time in the Western literature that says that MS is very closely related to HLA-DR-B1 and DQB1 alleles. But we did not find any association between those alleles and MS in Pakistan. We again find as a clinical follow-up that 1/4 of patients in Pakistan had severe disability. So, and they were very progressive kind of MS. So that's the clinical data we find out. Now, we found that his high disability is associated with primary and secondary progressive forms of MS and spinal MS. So if you have spinal cord lesions, there is higher chances of developing disability. At that time, we were not checking NMO antibody, so we did not know how many of them has optico-spinal kind of MS, or NMO antibodies were not available at that time. But what we found at that time, that was also, I think, that was very interesting, that there was a significant association between high disability and DQB10203 haplotype. So this is, I think, important for our part of the world, because that actually tells us that if someone who has got MS and has this kind of haplotype, then these are probable cases that they are going to develop very fast and they will progress very fast. And if we have a rationing of medications, so at least these are the patients who need disease modifying therapies as compared to the other ones, because they have a tendency to develop very fast progressing MS. So this is something important, that out of patients, this is also not only a good prognostic marker, but it's also an indicator that these patients need to be treated aggressively. Now, whatever we looked at the demography of MS in Pakistan, it's variable. So mostly it's again female predominant. The age range in Pakistan for MS patients which have been reported and published is about 29 years mean. There is a diagnostic delay. So every patient who comes, there is like a 6 months to 1 year or sometime a few years diagnostic delay. And there's a lot of undiagnosed cases now, we know that. We have a higher disability, but we also have a selection bias, because the data is coming from hospitals, and hospitals usually tend to see severe patients. They don't see especially neurology centers. And there is a rapid progression, but that again could be a selection bias, because most of the patients who come to see us, they are usually very aggressive forms of MS. So this is a problem with the MS demography in Pakistan. Largely, it's relapsing remitting, 70 to 90%. NMO or optico-spinal MS, if you look at the reports, it's usually 3, but there are some reports who have showed that it's maybe 20%. So optic neuritis in Pakistan is very common, and transverse myelitis is very common. And a large number of these patients, they do develop MS over a period of time. But we don't have any long-term data that how many of these patients develop MS. And so we don't also have this data that how many patients who have MS, they started with transverse myelitis or optic neuritis. So this is something I think which can be looked at if we are doing research in multiple sclerosis. Now, as far as MS treatment is concerned, there's no systematic study from Pakistan. We have published some data that what are we using in Pakistan. So steroids is a main therapy for acute MS exacerbation. Disease modifying therapies are less than 25%. So 75% of MS patients in Pakistan, actually, they are not receiving a disease modifying therapy, or at least whenever we have looked at the data, it has improved in the last couple of years. I'll tell you because of the some of the facilities the government provided in Pakistan. So, but still it's not more than 25-30%. And major issue is affordability of the medications. So that is one of the major causes, and this is something which has to be addressed. And we would like to address this at the governmental level and the social level. These are the disease modifying agents which are available in Pakistan in one or the other forms, and which are being used. So all of these therapies are being used in Pakistan. Out of one is not like FDA approved therapy for MS treatment is monthly steroid injections. But some people here, in especially Punjab, they are using monthly steroid injection as a disease modifying therapy. But otherwise, Interferons Pakistan available, have been available in Pakistan. Mitoxantrone is available. Teriflunomide is available. There are many patients on teriflunomide. Netlizumab, alemtuzumab, and ocrelizumab is available. Rituximab is available. Rituximab is a very popular medication in Europe, but it's not FDA approved. In USA, azathioprine, some people still use Immunon azathioprine, though it has not been studied well in MS. Plasmapheresis and IVIG, we usually reserved for only very severe cases with MS, but there are some cases who have been treated with plasmapheresis and IVIG in Pakistan. There's no data on MS outcomes in Pakistan yet, no systemic data. So a lot of people don't do EDSS in patients. We have, we look at a lot of us see MS patients, but we are not aware of the EDSS scale. So we don't have a good systemic analysis of their outcome. Mortality data is not available, that how many patients who with MS, they die over a period of time. Then there's also a selection bias. What we think that our outcome data is whatever reported from the Western data is worse than the European data, but that could be a selection bias too. This is a paper Haris published a few years ago, and that basically raised a question that Pakistan should have a national multiple sclerosis registry, which we are still trying to establish. This is a paper we published in Journal of Neurological Sciences a few years ago, and that's also an important paper highlighting the MS status and perspective in Pakistan. Now, disability is a major issue in MS, and this is one thing we did a study, and that was done during the COVID era, that we looked at that how if the patients are unable to come to hospital, especially in pandemic or some other reasons, you could even check the EDSS by telephone. And we translated this version of EDSS in Urdu and did it on telephone, and it worked very well actually. So a lot of time you can follow these patients by telephone EDSS and check their disability progression over a period of time. So this is something which can be incorporated, especially if you are running a multiple sclerosis clinic, or if you have a staff who could call the patient and check. So you will be able to find out the disability. And this is, I think, it's pretty concordant data. There is some difference. For example, we find that whenever we saw patient in the clinic, the same patients. So there were 47 patients, and they were seen in the clinic. So we recorded their EDSS, and then after few months, we checked their EDSS on telephone to see that what was the concordance rate between the clinical evaluation and telephone EDSS. So there was good correlation. In telephone EDSS, we were kind of reading higher scores as compared to in-person. But again, there was good correlation, and it was very good if you are seeing less than 5 or more than 5 of EDSS. So this is the correlation between the two. Now, in last year, in 2022, we published this largest study of MS from Pakistan, which is 188 cases. And it is largely from AKU and PIMS. So these two hospitals data basically. And that is also not only looking at the status of Pakistani patient, but we also looked at the availability and usage of multiple disease modifying therapies in Pakistan. So we have limited data at that time, and hopefully that in future we'll be able to collect more data related to MS in Pakistan. So this is a paper that has 188 patients. That was interesting. Now this is a paper we published, and this is, I think, which is important, that should be outcome of this conference too, that in previous Paktrims conference, we have various centers presented their data. And that's actually more than 200 to 250 patients altogether. We did not systematically analyze those patients' data, but this is, we published an analysis of their data. And this is also an important paper, that patients in how we are treating patients in Islamabad, and there was data from Quetta, there was data from SIUT Karachi. So there are different hospitals treating MS in different ways. And this is an important paper for people to study, that how MS is being treated in Pakistan differently at different centers. So this we hope that today we'll have presentation for 6 centers in Pakistan. So hopefully if we are able to combine the data, we will be able to again publish this as proceeding for this conference, which would be the second conference. And hopefully at some point, we will be able to get that data together. So this is what we are doing and what we plan to do in Pakistan. We established a MS Research and Education Forum, and Dr. Harris is the coordinator for many years. And our objective is to train doctors regarding diagnosis and management. So in 2019, we did 5 workshops, and we trained neurologists and doctors. And altogether, there was about 250 doctors who participated at these conferences. And we did a full day course on MS, and that was quite effective. Then in 2021, we again did 5 workshops in different parts. So we did like in Gawadar, we did Muzaffarabad, we did Jamshoro, different cities of Pakistan. And that was again very well attended by neurologists and internal medicine doctors. So that is the forum. And in 2022, we were not able to do any courses, but we did the Paktrims meeting. Now, this is one thing we are kind of struggling at this point. We wanted to start MS Pakistan National Registry. We already had the Android and iPhone app ready, so that was done. It was approved by Bioethics Committee in Pakistan a few years ago. And we wanted to enroll like from all centers in Pakistan. So our target was to get like 1,000 patients in 1 to 2 year period from Pakistan, and see that, from different parts, not like the large centers only, but the small centers which are seeing patients. So will be done in 2-3 minutes. So that is the same thing we wanted to do. The other thing is MS population-based study. So we have a grant, and hopefully it's 11 million rupees grant. If we are able to get, then we'll have the data related to neurological diseases in Pakistan. National Neurology Database, we have collected 40,000 patient data, and out of that 556 were MS. So at least we were able to identify that number, and hopefully we'll be able to publish that data. We started this Paktrims conference in 2021, and data was presented from 6 centers. We plan to organize this every year, and in 2023, we want to organize like a better represented conference. So in future, we want to start a mini fellowship. We want to train like 10, 12, 15 doctors for like intense 2 to 3 days program. There's an important aspect of MS coming, which is called cognition in MS. So we wanted to do a cognition in MS workshop with the help of neuropsychologists. And we want to work, collaborate with donor organization. This is an important problem. If patients are unable to find the funding for the medication therapy, and we are doing a special session on how to develop resources for MS treatment in Pakistan today. And JPMA has invited us to write editorial for MS, that's understanding the MS of Pakistan. So Dr. Harris is going to write the article. So in conclusion, MS is not uncommon in Pakistan, especially among young. Now, effective disease-modifying treatments are available in Pakistan, and we know that disability is high if not treated. And at this point, I think we all agree that all patients with MS, they should be treated with disease-modifying therapies. Established disease-modifying therapies in Pakistan. And doctors' training is important, especially the neurologist. And I think one of the most important things is that research related to MS in Pakistan may lead to improved care and less disability. So again, I like to thank all the participants on Zoom and all participants who are here. And hopefully these activities and conferences will lead to more information and improved care and identification of MS patients in Pakistan. Thank you very much.
Session. I'm really grateful. Today, I'll be discussing infection-related myelitis. I have nothing to disclose. General outline of my lecture would be, I'll first enumerate pathogens associated with myelitis, then brief overview of common pathogens we encounter especially in our setup, then post-infectious myelitis. Then I'll just tell you about diagnostic approach, especially in our setup, and then imaging approach. Spinal infections, they are pretty common. As we are all clinicians, we usually encounter 1 or 2 cases of spondylodiscitis in our clinical settings almost every week or so. But infectious myelitis, it's really rare. It's not that common. And at times, once it presents, then it's very important to differentiate from immune-related myelitis. There are a number of infections which can cause infection-related myelitis. These are bacterial infections, then DNA viruses, herpes viruses are very important. Then RNA viruses, out of RNA viruses, enteroviruses and flaviviruses, I'll be talking most. Then fungal infections, these are rare, but one may encounter occasionally. Parasitic infections still rarer, but one may encounter because Pakistan is endemic to so many parasitic infections. Now, just overview of common pathogens. Now, the most common are pyogenic infections. Obviously, it can be because of hematogenous spread or contiguous spread from associated spondylodiscitis, facet arthropathy, paraspinous infections, or meningitis. Staph is the most common, but other organisms, they can also cause this spondylodiscitis or pyogenic myelitis. Spinal cord involvement, generally, it comes in the form of spinal abscesses, epidural hematomas. Spinal cord ischemia can result from hypertension or vasculopathy because of the infection, and there can be an element of associated arachnoiditis as well. LETM, longitudinal extensive transverse myelitis, is usually rare with infections per se, but it can happen. The case reports have been there secondary to Neisseria meningitidis and Streptococcus pneumoniae. Now, there's one example of this pyogenic epidural abscess, and the spinal involvement, as shown in figure A, it's secondary to compressive myelopathy rather than the primary direct infection of the spinal cord. As you can see, the mode of, if you see on the transverse section or an axial view, the mode is just like extramedullary collection of fluid or abscess. Other infections can, like Mycoplasma pneumoniae and many other bacteria, they can primarily involve spine, and they can involve spine in a secondary manner as well because of immune-mediated mechanisms. And MRA would just demonstrate LETM, longitudinal extensive transverse myelitis. It's usually a centromedullary pattern. And this can be because of post-infectious or para-infectious reasons as well. And it's at times difficult to differentiate from immune-mediated mechanisms. But the bacteria, they can primarily involve the spinal cord. Now, out of atypical bacteria, Mycobacterium tuberculosis is the most important bug for us. Generally, the presentation is extramedullary, and there is a posterior predominant inflammatory exudates. Thoracic spine is the most common part of the spine which is involved. Then other regions can also be involved, cervical regions, lumbar regions, any part of the spine can be involved. Usually, there are multiple spinal segments, and there is an evidence of spondylodiscitis mostly. Myelitis can happen, and rarely it can happen alone as well. And more than 50% of the patients with myelitis secondary to tuberculosis, you will have evidence of arachnoiditis. And now myeloradiculitis is a presentation with many bugs, and it's a presentation, rarely a presentation of post-infectious myelitis as well. There is an involvement of spine, and as well as there is an involvement of the nerve rootlets or the nerves. Again, vasculitis secondary to infection or vasculopathy can lead to cord ischemia or ischemic myelitis. Now, here is an example of Mycobacterium tuberculosis causing a dorsal abscess. You can see there is a longitudinal extensive granulomatous exudate with subarachnoid effacement and hollow cord compression, and there is an element of intracord involvement as well, as you can see in the figure. So there is a possibility of, and there is an evidence of nerve root enhancement. So there is a possibility of tuberculous radiculomyelitis over here. So it is TB is one of the most common infections we encounter as a chronic infection in Pakistan. And now spirochetal infection, neurosyphilis, it is not that common these days, but one still encounters. Every month or so, you still find, every 2 or 3 months, you still find one patient of tertiary syphilis or neurosyphilis in our setups, although it's not that common as it used to be previously. There are typical specific MRI findings, which are usually not common, but rare findings. But if they're there, they're highly suggestive of neurosyphilis, like candle guttering and flip-flop signs, as I'll be showing you later. There can be longitudinal sensitive transverse myelitis, and again, ischemic myelopathy can be there. Osteitis and gamma can result in cord compression. And tabes dorsalis, it's a peculiar presentation of tertiary syphilis. It is sort of a tractopathy. It involves tract-specific pattern, and this tract-specific pattern, this is present in many other conditions as well. Nutritional deficiencies, paraneoplastic myelitis, and in many other conditions as well. And as well, I'll be talking later on. So in tabes dorsalis, there's a tract-specific pattern. Dorsal and lateral columns are involved, and it may result in cord atrophy. Now, this is candle guttering sign. This is because secondary to severe PL involvement and with linear and nodular foci on contrast enhancement. This is a specific sign for neurosyphilis. Diffuse cord edema, this is a centromedullary pattern on imaging, especially on sagittal view. This is non-specific. This can be present with any infection. And then flip-flop sign. It is abnormal parenchymal enhancement, which is relatively reduced on T2 images. As you can see in the images, it is also one of the specific signs in syphilis, but it's not common. Now, out of viral infections, herpes viruses, flaviviruses, and enterovirus, these are neurotropic viruses. And these are very important. And retroviruses, they usually cause chronic myelopathies. HSV2, it usually causes, myelitis is more common in HSV2 as compared to HSV1. And in severe cases, there can be hemorrhagic necrosis of the cord and encephalomyeloradiculitis. Myeloradiculitis, as we saw in TB as well, it's a feature of herpes simplex. If there is myelitis and acute lumbosacral radiculitis, and there is an evidence of preceding HSV, we call it as Ellsberg syndrome, but this presentation is common to many other bugs as well. So if there is evidence of herpes, then you'll call it Ellsberg. Otherwise, it is a presentation of many other bugs as well. And rarely, it is a presentation of MOGAD associated disorder and post-infectious immune-mediated mechanism. You can really see this pattern as well. So here are few cases in which there is myelitis and there is an element of meningeal enhancement and there is an element of root enhancement as well. So this is myeloradiculitis. Now this myelitis we see in many inflammatory conditions, but myeloradiculitis, it's more common in infectious diseases. But it can be a rare finding in inflammatory radiculomyelitis as well. Zoster virus, it is one of the viruses, many neurological manifestations. Generally, it's a subacute onset, and zoster can present, and usually it presents without rash. So one has to be very careful, and one has to have high index of suspicion for these sort of infections. It's more severe in immunocompromised. On imaging, there's a T2 hyperintensities of the ipsilateral dorsal horns and columns. So again, it's a tractopathy. So we find tractopathies in tabes dorsalis and again in varicella zoster virus. And the secondary reactivation of the zoster virus, which is lying dormant in dorsal root ganglion, and it becomes activated whenever there is T cell immunity against zoster veins. It can get reactivated, and there can be anterograde flow of the virus or the retrograde. And so you can have peripheral nerve presentations and you can have central nervous system presentations. And there can be enhancement and thickening of the nerve roots. So myeloradiculitis, again, a feature of varicella zoster virus as well. So here you see ventral root exit and dorsal root entry zones, hyperintense on T2 images, which is more obvious on transverse section or axial view. And this pattern is known as eccentric pattern. I'll be talking about this pattern later on. EBV virus, it can also result in radiculomyelitis, and it can result in longitudinal sensitive transverse myelitis. Enteroviruses, these are common all around the world. Fecal-oral transmission, there are many enteroviruses, enterovirus 71, Coxsackie viruses, echovirus and polyviruses, which are usually neurotropic. And usually clinical features are high fevers and neutrophilic or lymphocytic pleocytosis. And generally people have tried IV immunoglobulin in these cases. And there is a peculiar, enteroviruses, these have predilection for anterior horn cells. So frontal, the presentation would be anterior horn cell predominant, but these can present centromedullary pattern with centromedullary pattern as well. So it's very important to view the axial view. Because on sagittal view, all these would appear as longitudinal sensitive transverse myelitis or short segment transverse myelitis. But on axial view, you will have these peculiar findings. As you can see, anterior horn cell predominant involvement, and there is enhancement of the nerve rootlets as well. Flaviviruses, again, these cause flaccid paralysis. One of the most common flaviviruses which we encounter in Pakistan is dengue virus. Recently, we had a dengue epidemic almost in the last 3 months, and we saw so many complications with dengue virus. Now, here is an example of LETM with dengue virus. And dengue virus can cause lots and lots of neurological complications related to direct neurotropic effects of the virus, related to systemic complications of the virus, or post-infectious. So there's a whole list of neurological complications associated with dengue virus. West Nile virus, again, there is anterior horn cell predominant pattern on this transverse axis or axial view. And there is brain involvement as well, substantia nigra involvement, thalamic involvement. Again, similar findings, Japanese B encephalitis virus. There are brain findings and there are spinal cord findings. In spinal cord findings, you have similar findings like involvement of anterior horn cells. Zika virus has same findings because it's one of the flaviviruses. HIV, once we see myelitis in HIV, there is a whole list of differential diagnoses because there are so many co-infections. But HIV per se, it can cause myelopathy, especially in chronic cases, in long-standing cases, and it's HIV vehicular myelopathy because of secondary, because of involvement of macrophagic infiltration of the dorsal cord and the lateral columns. Again, it's a tractopathy, and on axial view, the findings are inverted V or inverted rapid ear sign. But this inverted V and rapid ear sign is not specific to any illness. There's a whole list of differential diagnoses, nutritional deficiencies, genetic ataxias, ALS, hereditary spastic paraparesis, and many other causes. These can result in similar findings. Fungal infections are rare, especially they are common in immunocompromised individuals. And there can be hematogenous dissemination, especially in Candida or in Aspergillus. But in immunocompetent, fungal infection can happen in immunocompetent as well, especially cryptococcal or Aspergillus, especially in diabetic patients. So this is a patient of histoplasma with leptomeningeal enhancement. I don't know whether histoplasma has been reported from Pakistan or not, but it has been reported from all over the world. Then here is a patient with Candida, and this case was recently published in Neurology Journal, and he was 56 years of age and no risk factors, no immunocompromised state. But initially he was diagnosed as a case of immune-mediated myelitis, treated as such, but once he did not improve, then they did genetic analysis and they found CARD9 deficiency, which results in poor neutrophilic response to fungal infections. And mucormycosis generally involves rhinocerebral mucormycosis, but rarely it can cause spondylodiscitis and associated myelitis. Now, parasitic infections, they are common in Pakistan, but we usually don't encounter many cases of myelitis with parasitic infections. Eosinophilia and peripheral eosinophilia is CSF eosinophilia is a marker towards parasitic infections. And here is a case report from India, our neighboring country. Case of malaria with LETM, responded just to anti-malarial treatment. Toxoplasmosis in immunocompromised can result in longitudinal extensive transverse myelitis. Now, coming to para-infectious or post-infectious myelitis, generally it's acute disseminated encephalomyelitis or myelin oligodendrocyte ganglioside antibody associated disorder, MOGAD. So this ADEM is a syndrome, and out of 50% cases of ADEM, they are associated with anti-MOG IgG antibodies. Spinal cord involvement is in 25% of the cases, and 2/3 of those cases would be LETM. So myelitis, the commonest involvement is optic nerve, and then is brain, and then is myelitis. MRI can be initially negative in 10% of the cases. And there is an H pattern described on axial view in MOGAD or ADEM. It's because of selective gray matter involvement. But this H pattern has been reported in other infections like West Nile virus or enteroviruses. And GAD enhancement is not a feature of MOGAD. There can be a faint leptomeningeal enhancement, but generally GAD enhancement is not a feature of MOGAD. Myeloradiculitis, as I've described in syphilis, TB, EBV viruses, or herpes viruses, this is also a feature of MOGAD, but not commonly. On sagittal view, you can see ventral sagittal line. I'll be showing you later. And MOGAD myelitis, there is a sign known as pseudodilatation of the central cross because of relative hypointensity of the central regions. And conus involvement is again another peculiar feature of MOGAD. It's also present in MS, but the spinal features would be different. And in cases of spinal dural AV fistula. Complete lesion resolution, it occurs in 80% cases of MOGAD. It's not a feature of NMSD, it only happens in 5% cases of NMSD. And in multiple sclerosis, contrast enhancement generally resolves, but lesions, they persist. So in the central figure, you can see a case of MOGAD. There is a sagittal linear line in on sagittal images, and on cross-sectional view, on axial view, you can see the H pattern. This H sign is present in 30% cases of MOGAD. But it's not specific to MOGAD. It's present in many other cases, but it's not a feature of MS, and it's only present in 10% cases of NMSD. And now you have to differentiate multiple sclerosis, where you have a peripheral posterior lesion. In NMSD, the lesions, generally in 90% of the cases, the lesions usually take up contrast. So GAD enhancement is a feature of NMSD. Sarcoidosis, generally the lesions are posterior subpial enhancement, trident sign on axial view. And in paraneoplastic, again, so paraneoplastic is again a tractopathy. If you see on axial view, you will see involvement of dorsal columns and lateral columns in 50% of the cases. Now the diagnostic approach, first of all, history, environmental exposures and travel history, whether you have to see immune status of the patient, whether it's acute. Generally, these infections, these are acute or subacute.
So you're left with 2 minutes.
These are acute or subacute, 1 to 21 days. Now examination, MR is the gold standard. So I'll skip other. And neuroimaging approach, T1, T2, fat suppression images, these are very important. And you have to see the axial views as well. I'll just suggest one pattern which is very important for in neuroimaging approach. I find it very, very practical for clinicians. These are 5 patterns: extramedullary, centromedullary, eccentric, frontal horn, and irregular pattern. These you see on axial views. So if extramedullary involvement is there, so as I've already discussed, TB and other chronic infections, I've already elucidated earlier. Then centromedullary, which is non-specific, it is present in many para-infectious, post-infectious causes, and is present in paraneoplastic causes, and present in many other inflammatory conditions. And this is centromedullary pattern because of HCV infection, chronic hepatic myelitis. Now, eccentric pattern I've already discussed with HIV, varicella zoster, treponema pallidum, and it's also present in paraneoplastic myelopathies. And this is zoster virus, as I've already discussed earlier. Now the frontal horn pattern, this is peculiar of polymyelitis, enterovirus, and West Nile fever virus. This is a frontal horn pattern. There is associated enhancement of nerve rootlets and leptomeningeal enhancement. Then the irregular pattern generally because of secondary to intramedullary abscesses or primary spinal cord infections. It doesn't follow any pattern. And here is an example of pyogenic intramedullary abscess resulting in irregular pattern. So infectious myelitis, related myelitis is an important cause of myelopathies and has to be differentiated from inflammatory, vascular, and neoplastic etiologies, especially in our country, because there are these infections, they are endemic to, so many infections, these are endemic to our country. So it's very, very important because we should not straight away jump to the conclusion that it's immune-related myelitis. their infectious causes. And in our country, if you have to see a clinical perspective, you have to do CSF examination. Now, previously, we had difficulty in diagnosing these patients. Now the tests are coming, all of these are expensive. Now there is one test being offered by important laboratories in Pakistan. That is, once you do CSF, they usually pick up pathogens and they give you report within 1 to 2 hours. BioFire, and this is meningitis and encephalitis panel, and it covers most of the common pathogens. At least there is a beginning, because most of the times we never used to have positive cultures, we never used to have positive antibody testing. Now there are important tests coming in our setup as well, so we can diagnose them, and they just give you report within 2 to 3 hours. So it's important that we evaluate these cases fully, and most of the times you have to do a complete systemic review. You have to do chest imaging for chronic infections, paraneoplastic, neoplastic, paraneoplastic, causes, and abdomen and other cells. Thank you very much.
So thank you, Dr. Wasim, for an excellent talk. We'll keep the questions and answer session at the end because we're running shortage of time. Our next talk would be a virtual talk. The next presenter is Dr. Burhan Chaudhry from USA. He's diplomat and American Board of Psychiatry and Neurology. He is a fellowship trained neurointensivist, neuroimmunologist from Cleveland Clinic, currently working as assistant professor in neurology at Tulane University. So he would be talking about upcoming therapies in MS and animal spectrum disorders. Dr. Burhan.
Can you guys hear me? Can you guys hear me? Okay, right. I'm sorry. Right, okay, thank you. Yeah, I'm sorry about that. I'm not really sure what happened. I was connected and then all of a sudden I was kicked out. Anyways, thank you so much for having me, Professor Wasay, Dr. Harris. Really appreciate you inviting me and giving me an opportunity to present to you, the exciting times that we are currently in when it comes to specifically MS and the entire DMT horizon, where we are right now and where we're headed. So next slide, please. We all know this slide really well, the clinical stages of MS. Over here, I have laid out clinically isolated syndrome. Then you have relapsing, remitting, and then the progressive phases of the disease. This slide, as you see it right now, has changed over the years. And if you ask me, this will probably be obsolete in the next 5 to 10 years. Our approach to MS, how we think about this as a disease, has drastically changed over the last decade. Now it is a fact that it's a neurodegenerative process. So the progressive phase of the disease is essentially starting from day one. We always thought that this is a stage of multiple phases. Inflammatory phase. Inflammatory phase is the early part of the disease, which we see in relapsing, remitting, and then secondary progressive as well. And then after the inflammatory phase, we should have a progressive phase. But that concept has been thrown out of the window. We have really good data. There's really no doubt that the progressive phase of the disease starts on day one. So disease is a spectrum. It is not divided into different phases. And we have really good data. Professor Wasay talked about this as well. The data in Pakistan has showed that if you do not treat early, your outcome is worse. That's why it's really important that when it comes to even clinically isolated syndrome, we have really good data now. Paktrims, which was held earlier this year in Amsterdam, they presented data from radiologically isolated syndrome. Patients were treated with dimethyl fumarate, Tecfidera. Those patients did much better than patients who were on placebo. So the paradigm has shifted. Treat early, treat early. When it comes to stroke, there's a very famous tagline, time is brain. We try to treat acute, try to treat stroke acutely. We try to give them a clotbuster as fast as we can, because we're all concerned about with every second we're losing a lot of neurons. When it comes to MS, we should have the same mindset when treating these patients. Treat early. We should not wait around. So next slide, please. And this slide I have shown up over here. I will go into it. If we could come back to this slide, please. Let's move on to the next slide. I'll come back to this slide. And so how I talked about that, we need to treat early. Early. This is a brief overview of what the landscape looks like when it comes to DMTs. We have come a long way. There are over now more than 20 FDA approved MS therapies in the US. And Pakistan is very fortunate that they have access to some very good DMTs, as Professor Wasay just presented. It's very heartening, but it's also why the setup of Paktrims is so important. And I'm really, really glad that, Professor Wasay, along with Dr. Harris and others, took this initiative, because he mentioned that there's still monthly steroids are being given to patients. That should not be happening. So that's why it was heartening to see that, Pakistani neurologists have access to a lot of these DMTs that are over here. And why is this slide important? Because I have set this up to give you that what is the efficacy like and what is the safety like. So monoclonal antibodies, ocrelizumab, rituximab, natalizumab, alemtuzumab. These are our monoclonal antibodies, and these are really, really efficacious DMTs. They do a really good job of really nipping the inflammatory phase of the disease in its bud. Then we have our oral DMTs, of which what's it called? Professor Wasim mentioned that teriflunomide is now available over there, and the platform therapies have been available over there. So the monoclonals are really, really efficacious, and their safety profile is pretty good as well. And then you have the oral DMTs, or the injectable DMTs, which have a good safety profile, but their efficacy leaves a lot to be desired when compared to the monoclonal antibodies. And with that in mind, I want to talk about two trials, which will be really, really important to how the MS DMT landscape pans out and how we manage our MS patients. So next slide, please. And so we have talked a lot about in MS over the last 2 years is that we have these approaches to management. Escalation therapy. Escalation therapy has been the mainstay of MS management, and what that really entails is that there is a stepwise DMT approach to our patients. Let's say you diagnose someone with relapsing remitting MS. Historically, if the patient didn't have any lesions, if they didn't have a high EDSS score, neurologists would wait. Be like, okay, we don't need to treat now. Let's see what happens. If you have a relapse, if you have more lesions, we'll think about it. And then we would wait. Then after some time, if the patient has a relapse, you would go with the platform therapy because it's safe. But the efficacy, like I said, leaves a lot to be desired. So then again, you put them on the platform therapy, and then again you wait. A year passes, 2 year passes, they do fine, but then again they have a pretty bad relapse. Then you go on to a higher efficacy DMT. It could be either one of the orals with the higher efficacy, or it could be the monoclonal antibodies. This whole process used to take about 6 to 8 years. And that whole time, patient is losing time. There is silent disease activity going on in the background, because we forget the only real biomarker we have for MS is imaging, is MRI. And our MRIs, a lot of centers have 1.5 Teslas. Not a lot of centers have access to 3 Teslas. Even 3 Teslas, you can miss a lot of things. So our ability to catch activity is not really well tuned yet. That's why that time that was being lost with the escalation therapy is not, the patients cannot get that back. If the EDSS score goes higher, they get more lesions. Then we came to induction therapy. Induction therapy is early, higher efficacy therapy. As soon as you diagnose your patient, regardless of relapsing remitting MS, secondary progressive MS, clinically isolated syndrome, even now, as I mentioned, radiologically isolated syndrome, you start treating them on day one. And you do not start with your platform therapies. You do not start with your oral DMT